Most of those other treatments, I'm just not going to do. But what I do regularly do is give a PDE5 inhibitor. So a phosphodiesterase 5 inhibitor. This is Viagra, right? This is a medication. This is probably even for the serotonin induced, this is the most effective thing. And in the system that I used to operate in, TRICARE was our insurance provider. And if you wanted to prescribe one of these medications, um, the patient had if they had to be over 40 or they would 40 or over or it wasn't approved. So everyone operates in their own insurance systems. These are expensive medications. So for insurance to pay for even the generics, they're still pretty expensive. We're talking like $20-$30 a pill or something. So um, might totally be worth it to the patient, but they may have to pay out of pocket. So for us in the military, it was if you were 40 or over, I could give it to anyone. But if you were under 40, you had to be on a serotonin medication that, I felt was causing it. And if that was the case, I could give it to people under 40. So this was actually probably my go-to. Whereas a lot of people I think reach for bupropion, I reached for the PD5 inhibitors. I just think that they're a lot more likely to work and the risk is pretty low. And so it's kind of like, when you're treating ADHD, reaching for Strattera bupropion first, I feel like is just like not the best idea. Like, let's, even though there's a little more risk, with the Adderall or the Concerta, they're way more effective. And some people, they might want to just, let's try the, safest thing first and see how that goes. I'm kind of like, I see the writing on the wall. I don't think this is going to work. Let's go with something that is more likely to work. If this didn't work, then maybe I fall back on the other one. But I like the PDE5 inhibitors. This is probably this, like I said, this is my go-to for this symptom. And so I'm going to spend some time on those. So what are they? There's actually 5. I think most people are probably only aware of 3 of them. I've got a chart here that kind of compares their differences that I'm looking at, and you can look at on the slides, and hopefully YouTube is working by now. So sildenafil, that's Viagra. First one that came out, the little blue pill, 1998. Um, Next, alprostadil, that's Caverject, Caverject, I'm not sure how to pronounce it, came out in 2002. This is an interesting one. This is one that's injected into the penis. And there's also one that I don't know how this works exactly. I haven't seen it, but you put it into the urethra. So it's kind of like uh, this is the only medication I know of that you like shove down your urethra for it to work. I should look this up and see what it looks like, how big this thing is, because I really don't want to put anything inside my urethra. So anything, for patients, the urethra is where you pee out of. So and I really don't want to stick a needle in my penis either. So, and I think most people probably don't. And this Caverject alprostadil is something that you would have to see a urologist for, and you failed everything else. And the way it works is they actually inject you in the office and they monitor you, wait for the erection to go away. They find the right dose. They test you on a few different days. And then eventually, when that's determined, you inject yourself at home. And so this is definitely urology only, as far as I'm concerned. Next is vardenafil, that's Levitra, came out in 2003. Then we got tadalafil, Cialis, came out in 2003. And then Avanafil, Stendra, came out in 2012. So what are some of the differences between these medications? So there's different onsets of action, different half-lives. Um, they, they actually also can affect your PDE1 and 6 receptors as well. And so they have variable amounts into which ratios in which they affect your PDE5 versus PDE1 or your PDE5 versus your PDE6. They have a little bit different side effect profile. Taking them with an alpha blocker, there's caution to do that, and the caution differs between the medication. And then there's some different effects if you take them with food. So let's discuss this, right? So onset of action, everything. So the injectable one works really fast. So 5 to 20 minutes is the onset of action, and its half life is very short, half a minute to 10 minutes. So that's, I mean, I don't know if that means you have to finish really quickly or if it lasts longer than that, but that's the half life. When I looked up the medication, pretty short half life. Um, I don't know. I know almost nothing about that medication. Like I said, this is all urology, but I want to put it on there because we're talking about this stuff, right? So that one does have a faster onset of action, which makes sense because you're directly injecting this thing into yourself, right? 5 to 20 minutes. Sildenafil, vardenafil, and tadalafil all have about an average of an hour before they work, in between 30 minutes to 2 hours before their onset of action. Avanafil, the one thing that sets Avanafil apart from the rest of these is that it works a little bit quicker, 15 to 45 minutes. So a little bit faster onset of action with Avanafil. I have never heard anyone talk about Avanafil. I've never seen it. I've never given it. I don't. I barely even knew that this drug existed, and I've listened to several. I've listened to a lot of talks about this topic, and no one ever talks about Avanafil. So if you know something about Avanafil, comment down below because all I know is that it might work a little bit quicker, and that's pretty much it. And I assume it's more expensive because I don't know. You never see it, but the other ones all take about 30 to 120 minutes to work. Half life. So we already talked about Prostadil. 30 seconds to 10-minute half life. Sildenafil is 4 hours. Vardenafil is 4 to 6 hours. Avanafil is 5 hours. All about the same. Tadalafil, this is one thing this is the big thing that sets a Tadalafil Cialis apart. 15 to 17-hour half life. It basically lasts all day. This is the one where, if you're watching the TV commercials, it's like, whenever you're ready, you don't have to take it and then be able to have your sexual activity 1 to 2 hours later. This one, you can actually take it in the morning and have sex that night. It's still working for you. So that's a big benefit for tadalafil. I mean, this is really, in my opinion, tadalafil Cialis. That's the one. In the system I was in, they had to take Viagra first. So first I had to get Viagra approved to begin with, and then they had to fail Viagra before I could go to Cialis. So, every insurance is different, but tadalafil, that's amazing that you don't have to basically anticipate you're going to be having sex in the next 1 to 2 hours because it's going to wear off, right? Tadalafil doesn't wear off. It takes a day. And then looking at the PD5, PD1 ratio, there's some adverse effects that PDE1 can cause. PDE1 is found in the brain, heart, and vascular smooth muscle, causes vasodilation, flushing, and tachycardia. That's actually what we want to avoid, a big thing that we want to avoid. And hey, tadalafil is actually the least likely to cause this. On average, 1,000 to 1 ratio. So 1,000 PDE5 to a 1 of PDE1. So it's 1,000 times more potent on the thing that we want it to be potent on. Vardenafil is 200 to 1,000 times. So similar, but maybe a little less. And then sildenafil, the number I have is 80 to 8,500. So it could be a lot less or a lot more. And then PDE5 to PDE6 ratio, sildenafil 9 to 1, vardenafil 16 to 1, tadalafil 1,000 to 1. So tadalafil also really not hitting this one. And PDE6 is found in the eye, can alter color perception, super rare. As far as adverse effects are concerned, patients tend to complain more about Viagra sildenafil. So it tends to have the worst side effects. But from my experience, most people don't complain about it. I don't. I don't really hear about side effects. I hear more like it just didn't work. All right. Next, we're talking about alpha blockers. So an alpha blocker, remember, is a blood pressure lowering medication. Well, what does PD5 do? How does it work? I didn't mention this, right? So PD5. So these medications we're talking about, they inhibit PD5, and PD5 has an effect in the smooth muscle of your vasculature in your penis, but also elsewhere, right? As we discussed, right? But in the penis, that it vasodilates, which causes more blood to be able to go in there. And of course, that's how erections happen, is, you have more blood in the penis. All right. So when you dilate your blood vessels, that can drop your blood pressure, right? Because if you think about it, if your blood vessels are taking up more space, you have the same amount of blood in more space, that's going to be less pressure, right? If you tighten your blood vessels, that's going to be the same, because you're not changing your volume. Your volume of your blood is not going to respond as fast as your blood vessels are to tightening and loosening. And so if you loosen your blood vessels, that's going to lower your blood pressure. And so we don't really want to take these with other blood pressure lowering medications, especially um, uh, alpha blockers. So, and one other type of medication I'll mention in a second. So because sildenafil and vardenafil and avanafil have half-lives of around 4 to 5 hours, it's recommended, if you're taking an alpha blocker, to take it 6 hours apart. And so what are some alpha blockers? Those are meds that we use for enlarged prostate and nightmares and PTSD. And so if it's an as needed, you may, not take it, because if you're taking them both in the evening, don't do that, right? Because if you're taking it for nightmares, you got PTSD, and then you're having sex that night, do not take that alpha blocker within 6 hours. So that would be a night to skip that alpha blocker, or have sex 6 hours before you take the alpha blocker. You've got to take them 6 hours apart. We don't want to have a dangerous drop in blood pressure. So I think that's when this really comes into effect. A lot of people with PTSD have this problem, and a lot of them have this problem because they're taking a serotonergic medication. And so you're giving them a serotonergic medication, you're giving them an alpha blocker for nightmares, and then you're giving them a Viagra to help with the side effects from the serotonin medication, and then you don't tell them to take that 6 hours apart. Boom, not good. Okay, and then this is the one downside to tadalafil, because remember, it's got the long half-life. You cannot take Cialis with an alpha blocker, not on a regular basis. All right. You need to space it out 1 to 2 days instead of 6 hours. And so if your alpha blocker is a medication you take every day, you could space it out 6 hours from the other medications. But if you're taking it every day, if it's for nightmares, you don't necessarily have to take it every day. If you're on a high dose, I wouldn't recommend taking a high dose some days and not taking it on other days. That could really mess with your blood pressure. But if it's something that you have to take every day, you are taking every day, you can't take tadalafil. Okay. You've got to space, they have to be spaced out 1 to 2 days. All right. So that's the one big downside for Cialis. And then food. So if you take it with food, it can slow the absorption. So it could take with Viagra, it could take longer to work. Same thing with Avanafil. Less Levitra, a little bit less on this one. Vardenafil, a little bit less effect of the slowing down with food. And tadalafil, hey, boom, another great thing, no effect. You can take it with food, doesn't affect it. That long half-life kind of like cancels that all out. So those are the summary of all of our PDE5 inhibitors. So we talked about what PDE1 does, 6. What are some of the adverse effects? So I mentioned that Viagra has maybe a little bit more of these adverse effects. So what are they? Headaches, nasal congestion, facial flushing, stomach, back pain. But here's a big one, a big bolded no priapism. What's priapism? Priapism is an erection that doesn't go away. Okay. So this is a myth. And a urologist, a very good urologist that I listened, that was giving a talk about this at a conference, she said, these do not cause erections that don't go away, right? That's what priapism is, a dangerous erection that doesn't go away. She said, this is not something that happens, right? So this is like stop being worried about this. And I almost don't want to believe her. I want to believe her, but I almost don't believe her. But she certainly knows a lot more than I do, because she does. I mean, she does the injections and stuff. She's doing the real deal. She's putting in pumps, penis pumps, and things like that. She does it all. And she's saying no priapism. I trust her. All right. So that's an excellent thing to know. We mentioned the combination with alpha blockers. Don't do it with tadalafil. 6 hours with the others. If you're taking a couple of milligrams of prazosin for nightmares, and you're not doing it every day, but you probably should. You need to space it out several days from the tadalafil. But like, really, I would not give patients both of those medications at the same time, because like, I just don't want to take this chance. I can tell them 6 hours separated with the other ones, but if I'm giving them tadalafil, I'm not giving the alpha blocker. I'm just not going to give it to them. All right. So fatty foods delay absorption, except tadalafil, less so with vardenafil. And then the other blood pressure lowering medication that we have to be careful with are the nitrates. All right. So these are like the isonitrocarbide. I can't remember all the names, but these are the medications that patients take when they're having chest pain. It helps dilate the vessels in your coronary arteries, so that if you're having signs that you're about to have a heart attack, you take one of these medications, and it makes those blood vessels expand so that the blood can flow through and get oxygen to your muscle of your heart tissue. You can't take a nitrate within 24 hours of these medications, 48 hours for tadalafil. All right, that's very important. It could cause cardiovascular collapse. Like, taking a nitrate with one of these medications can just bottom out your blood pressure beyond belief, and it's just a really bad deal. So 24 hours except tadalafil, 48 hours separation. All right. Here's another cool thing about tadalafil that I learned from that urologist that I mentioned. So she actually was saying that, like, you can dose. So tadalafil has another FDA approval other than erectile dysfunction. It also has an FDA approval for LUTS. So that's lower urinary tract symptoms, otherwise known as enlarged prostate. So, your prostate's enlarged, it's hard to pee. Um, we take the alpha blockers typically for this, right? And remember, I said you can't take an alpha blocker with tadalafil, but hey, tadalafil can be used instead of an alpha blocker. It might help with that exact thing, right? So we don't even need the alpha blocker if that's what we're using it for. If you're using it for nightmares, then you're kind of have to choose which one you're going to take. But if you've got the enlarged prostate, the tadalafil is actually FDA approved for this. And this is the awesome thing, right? So remember, patients don't know necessarily when they're going to have sexual activity. And that's the great thing about tadalafil, is you can take it in the morning, it still works at night. However, do you even know you're having sex that day? Do you even want to have to plan? Is that take some of the spontaneity and the fun out of it? Right? So the thing is, if you're prescribing these medications um, for erectile dysfunction, or my insurer, TRICARE, only allowed me to give, like, I think 15 a month, right? But what if you want to have sex every day, or what if you don't know when you're going to have sex, and it could be only half the days, but you don't know which half it is, right? Because it just kind of depends on what happens that day. Um, this is the cool thing. If they do, in fact, have LUTs, you can give them tadalafil every day and insurance will cover it, right? And so then that you're taking it every day, and then, hey, you've got it on board to help you with that erection every day if you need it. Now, otherwise, the patient may have to pay out of pocket, and we use lower doses. Look up the prescribing guidelines, but it's typically like lower doses if you're using it on a daily basis for LUTs. But you don't, because you're getting to steady state, because you've got it in your system every day. And remember, the half life is so long, you actually don't need as high of a dose, so you can actually get away with. This is a great thing. And a tip she actually mentioned was, hey, if your insurance company only pays for 15 a month, give them the 15 a month, but tell them, hey, you can actually take half every day, and then you won't run out, and you've got it on board every day, and we're at steady state, and we're taking it every day, and maybe they don't have LUTs, but we can take half the dose every day. So you know this is just so many reasons. I feel like this episode's turning into a commercial for tadalafil because of everything I've told you up to this point. I think tadalafil is like my favorite. I mean, the cost and everything may be the issue with it, but like as far as effectiveness and ease of taking it and adverse effects and just like all around, other than the alpha blocker issue. And remember, we get around the alpha blocker issue for enlarged prostate because it can actually treat that. So tadalafil, tadalafil, tadalafil. All right. And so what happens if you're taking a PDE5 inhibitor and it doesn't work? Well, and I see this all the time, you can take more. So like Viagra, for example, is 25, 50, and 100. Sometimes patients only take 50. Well, hey, if you're having side effects on 50 and it works, you can go down to 25. And if it's not working on 50, you can try 100, right? And this is another way that you could potentially get a medication to a patient more often than their insurance company will provide, hint, hint. You could give them the high dose and tell them to take half because maybe they only needed the 50. And this is the crazy thing. When you look at the price of these medications, and I want to do an episode on drug prices because I think that would be an awesome episode because I think it's something that doctors just don't know that much about, right? If you look into this, the price of drugs is often not different for different doses. Sometimes it is, sometimes it isn't. But like, I was just looking at the weight loss medications yesterday. If you look at like Wegovy, from the 0.25 up to the 2.4, every single one of those doses costs the same. It doesn't matter if you're on the lowest dose or the highest dose. And I think they probably do that because in their prescribing guidelines, they say, oh, you have to titrate up. And I guess they figured they'll eventually be on the highest dose anyway, and they want to get the same amount of money the entire time. Right. But the thing is, you could, so that's where to save the patient money, if they're having to pay like out of pocket or copay or something, you give them the higher dose and tell them to take half of it. Right. So you could tell them to get the 100 of the Viagra and tell them if they only need half. You could even write in there. You could even write in there, to be even more honest, take half to one as needed. And if you write half to one, that means the pharmacy can they'll fill up to one for a month's supply. So, and I don't know if the patient maybe needs half some days and one other days, right? I mean, who knows? If they only need half and they want to have sex every day and it works for them and they're taking half of that pill every day, then there they go, right? And that way you can actually get it to them. So, but at the same time, they may need that 100. Okay. So take heed at what the max doses are. You can please go up to the max dose. That's what they're there for. The lower doses don't often. I've had patients come to me, it didn't work, and I'm like, well, did you try 100? No, I didn't know I could try 100. I'm like, well, you sure can. I'm going to give them to you. All right. So if they're ineffective, make sure we're going to the max dose. Don't take with a full stomach or fatty food, right? Because remember, that can slow their absorption. You got to take up to. Here's the other thing. Remember, it can take up to 2 hours to work. So they may say it's not working, but really, remember, it takes 30 to 120 minutes, except for Avanafil, which works about twice as fast. The rest of them take up to 2 hours to work. So don't expect it to maybe work in an hour, because I think it says, an hour before sexual activity. Well, it might be 2 hours. Okay. So keep that in mind. And here's the other thing. Sexual stimulation is still required to achieve an erection. I think there's this myth out there, and I've taken a lot of the meds that I'm going to talk about, and I'll tell you when I've taken a med, so I can give you my own personal story, because I think that leads credence to what I do. And you may be like, oh, he has experience. He's actually taken this. He can actually speak to this. I've taken a lot of these medications. I've never taken any of these. Never taken any of them. Right. So I can't speak from personal experience, but like, once again, I got this information from this urologist. You still have to stimulate. You're not just going to get an erection out of nowhere. Okay, don't expect that. You still have to like do foreplay. All right. I know the women are wanting to hear that. So those are the adverse effects of the PDE5 inhibitors. The last thing I want to talk about are supplements. So these are things that we can't prescribe to patients, These are things that you could potentially recommend a patient to buy on their own. And it's also something a patient may have taken on their own. And you may know nothing about this. I think this is a big gap in medical education. They don't tell us about the supplements because we can't prescribe the supplements. But guess what? The supplement industry is a multi-billion-dollar industry. People are taking the crap out of these. And if you don't think people are taking medications on their own that they're buying through the internet and from the GNCs or wherever, to enhance their sexual performance, then you're blind. They're doing it. And so you need to know what they're taking so you can be like, okay, I actually know about that. I can actually tell you there's evidence for that. There's not evidence for that, or, whatever. So let's talk about the ones that are the most common and maybe have the most evidence for working. Okay. First is epimedium. That is the plant's name. It's a Chinese plant known as, and I don't speak Chinese, yin yang wo. I'm not sure where to put the intonation on that. I do read Japanese, and I looked at the characters. I know the middle character Yang is the character for goat, and the first character Yin is in Japanese pronounced Ing, actually. And it's it's like it means kind of like lewd, vulgar, salacious, not salacious, but like sexual. Okay, so that's what Yin means, and Yang means goat, and then Wo means like that's a type of plant. Okay, so the English name actually is horny goatweed. If you've heard of it, or if you search it, you will find it everywhere. And it's like, why is it called horny goatweed? Well, I guess some people saw some goats eating it, and they looked like their sexual activity had increased, and there it got its name, horny goatweed. So it's this is a really common one that's out there. The active compound is incarin. I'm not sure how to pronounce that. INCARIIN. It's a weak PD5 inhibitor, and there's limited information that it works. It might not. It works a little bit like your Viagra and so forth works, but it's not as potent. So maybe potential. The risk is pretty low on this one for taking it. So that's that one. That's the horny goat weed. Next, saw palmetto extract. What the heck is this stuff? So I've seen that it contains a 5-alpha reductase inhibitor and perhaps also has some PD5 inhibitor functioning as well. So 5-alpha reductase inhibitors, those are medications we also use for enlarged prostate. They take a really long time, like months, to shrink a prostate, but they basically block testosterone changing into another chemical, like a dihydrotestosterone, something like that, DHT, something like that. I don't have it right in front of me, but it contains a little bit of that. And so there's some thought that it might help with LUTS, prostate cancer, but the evidence doesn't help with prostate cancer. Maybe there's like one study that showed that it helped with LUTS, but several others that showed that it didn't. No evidence that it helps with sexual enhancement. So I don't really think saw palmetto is something to be thinking about taking. The horny goat weed, maybe. I would probably put it just above saw palmetto. Next, yohimbine. All right, so yohimbine, 5.4 milligrams, 2 to 3 times a day. This is actually an alpha-2 antagonist and a 5-HT1A agonist. So it actually has some of those effects of the meds we talked about before. It's actually derived from the bark of an African tree, the yohimbe tree, but limited evidence for it working. And I've actually had some patients that have taken this, and they told me they got like flush and like heart racing, and they did not like the way they felt, and they didn't really feel like it was doing what they were hoping it was going to do. So I've actually had patients take saw palmetto and horny goat weed too, and everyone that's told me about it said that they didn't really notice much benefit. And then the yohimbine, they noticed some side effects they didn't like, but they didn't notice much benefit. Next, ginkgo biloba, 60 milligrams a day, or 120 milligrams, and max dose 120 milligrams twice a day. This may increase nitrous oxide, so that could, increase that blood flow to the penis. Limited evidence for it working. Ginseng, particularly the red ginseng, looks like it has the most evidence. This one looks like it may have some more evidence for it actually working. It also increases nitric oxide, but also increases dopamine, some GABA A. Ginseng does a lot of stuff, and it's a lot of people take it. I mean, if you've ever seen it, looks like a white gnarly carrot. It's popular in Korean and Chinese medicine, and there's a Korean, one of the most popular Korean hot pots. I think it's called like Samyung. I don't speak Korean. It's like Samyukgung or it's something. It's like 3 syllables. It's like this soup. It's got jujubes in it, and it's got like a whole chicken. I made it one time, and I bought ginseng. This is why I know about it. I bought ginseng the only time I ever bought it so that I could make this dish. It adds a flavor. A lot of people think ginseng helps with a whole lot of different stuff, and one of the things they think it helps with is erections. So, and this is one of those Chinese medicine, things that I think herbal type of things that there might be. I would probably put ginseng out of everything we've talked about so far, at the top of the supplements. And then the next one, maca, I would put kind of with ginseng. So maca is known as Peruvian ginseng, but it's not related, even though it's called that. I don't know if it looks similar or what. But from whatever I could find, there was some evidence that it might help, but I couldn't find anything about like what its mechanism of action is. Like, how is it doing this? It looks like they don't know like how it works. So the maca and the ginseng are probably, out of these supplements, the ones I would favor the most. Then maybe the ginkgo biloba, horny goat, we would be next, and the saw palmetto and the yohimbine at the bottom. And then the last one that I want to talk about are the quote unquote rhino pills. Now, I spent a lot of time in Japan, and so when I went back to the States, for my last tour in the military, I went to the 7-Eleven to get something, and I saw these giant pill packs, and it was like 1 or 2 pills that were these huge capsules, and it said like rhino or tiger. They've got just tons of these kind of like alpha animal names, right? They're sold at convenience stores. Do not take these. And if your patients are taking these, find another option. If this is what they're going for, give them the Viagra. If you're like holding out on giving the Viagra and the patient's going like taking rhino pills from the convenience store, maybe we need to think about like some harm reduction here. Because the thing is, the FDA has basically spoken out against these. And I don't, if they're saying they're dangerous, then how are they even still allowed to sell it? And what they're finding is when they're looking at what's in these pills, it's a whole bunch of crap. And some of the crap that's in there, sometimes there's actually like sildenafil or vardenafil, or the PDE5 inhibitors are in there, and then some of them have like PDE5 inhibitors that are not FDA approved. So there's actually like a handful of other PDE5 inhibitors. Some of them are approved in other countries, some are not approved anywhere, but some chemists just made them, and they inhibit PDE5. They have the same ending in the enil ending, and or Phil ending, and they're in these friggin' rhino pills, and it's like, oh, I'm gonna go to the local convenience store and buy a giant rhino pill and have the best sex of my life. Like, not a good idea. There's just, we don't know what's in it. It could be, we don't know what the dose is. You could get like a really low blood pressure from this. Please, if you're a patient and you're listening to this, don't take these. I hope I'm not in the States anymore. I hope that they're not there anymore. But I wanted to end the podcast on a cautionary don't take rhino pills message. But I hope that, this is a pretty long episode, but this is a really, really, really important topic. And the thing is, I think this is like one of those things that we're like, as a doctor, you're less concerned about the things that won't kill a patient, but it's the exact thing that the patient's really, really concerned about. And I think that makes sense if you think about it, right? Like that should make sense to you, that patients are going to be concerned about decrease in their sexual functioning, right? Even if they are depressed. Don't think just because they're depressed that they're not going to be concerned about this. They are. Not all of them, but don't take it for granted. Ask, tell, guide them through it. Take the information you got from this probably hour and a half of information of what to do about this very important topic. And, counsel your patients and make the changes to their meds that we discussed here. And you're going to have happier patients that are going to love you a lot more. Okay, so I hope you really found it helpful. I hope this was like super informative, and like, I think you probably knew a lot of this stuff, but I think there's some meds that we talked about you probably never heard about. I think there were some supplements you probably never heard about. I think I even put together some of these supplements right before I recorded this. Like I had heard of all of these, but I wasn't sure like how they worked. And so like I actually just learned about like some of the mechanisms of action and like which ones have a little bit more evidence for working right before this. So like I just learned something too. Like this, I've in my opinion, I think this is probably one of the most important episodes that I will ever do on this podcast. And so I hope that you all found it to be as interesting and helpful as I find it to myself. So thank you for joining me, and I'll see you next time.